Hello everyone, welcome to my YouTube channel where I make pharmacology simple for everyone to understand. Now, have you ever wondered why or how some people get a condition called Parkinson's disease and why we use the medications we use? Now, if you are curious to know, I would want you to follow me on this journey while we explore drugs for Parkinson's disease. This is Professor Kennedy Edem Kukia, and I'm happy to have you here. Now, when we talk about Parkinson's disease, what really happens or what is it? This condition is described as a progressive neurodegenerative disease of movement that is associated with the death of neurons in the substantia nigra. So let's explain. Now, in this condition, there is the death of certain neurons that we find in a particular part of the brain called the substantia nigra. So this part, this portion, we call the substantia nigra. Now, in the normal brain, this is how it looks like. But someone that has Parkinson's, you realize that the pigmentation is basically gone. So this happens gradually. Now, these portions that I've circled, they contain neurons, okay? And in people with Parkinson's, these neurons die progressively. And at a point, the death of those neurons creates a situation where there are certain symptoms they manifest. Now, the neurons found in the substantia nigra are neurons that basically produce what we call dopamine. All right. And because they are supposed to produce dopamine, as these neurons begin to die, the levels of dopamine that you have in that part of the brain will reduce. So the person creates, or the person has a condition you would describe as associated with dopamine deficiency. Now, the symptoms the person may present with may be a number of them. There may be several symptoms, but we have what we call the Parkinson's triad. We have bradykinesia, also known as hypokinesia. We have muscle rigidity, and then we have tremors at rest. There could also be some cognitive symptoms and autonomic symptoms. But let's move on. Now, let's try and appreciate what really is happening. So we are saying that in this person with Parkinson's, the neurons in the substantia nigra are dying. Now, let's pick probably cell body. And then let's say this is the terminal, okay, of a normal neuron in the substantia nigra. These neurons are traveling to, so if this is the substantia nigra, these neurons are traveling to a part called the striatum. Let's make it ST. And then these neurons make connection with other neurons, but for now, let's keep this one as our cholinergic neuron. So we just write CH, and this one releases acetylcholine. So normally, what will happen is that when dopamine is produced by the first neuron, it releases the dopamine here, okay? Then this dopamine will act on the second neuron and then suppress the activity of acetylcholine. So it means that acetylcholine activity goes down in the normal neuron. And this is what ensures that we are able to control voluntary movement. Okay. Now, in the person with the Parkinson's disease, we are saying that this person's neuron in this area called the substantia nigra are destroyed. So dopamine levels would be low. Okay, dopamine levels are low. Now, since the dopamine levels are low, that inhibitory effect the dopamine levels must have on the cholinergic neuron is now removed, meaning that acetylcholine activity goes up. Now, it is the increase in acetylcholine activity that creates the tremor, okay? Now, if there is enough dopamine released by the first neuron in the normal brain, this is released in the striatum. And in the striatum, the activity of the dopamine there is to regulate voluntary movement and other activities, all right? So if the dopamine levels go down in the person with Parkinson's, then those voluntary movements become abnormal. And this is where we have the bradykinesia and then probably the muscle rigidity. And so basically this is what is happening. So you would appreciate that in the condition, one, we have dopamine deficiency, and two, we have cholinergic activation. These are the problems we are trying to address when it comes to the drugs. All right. So where do drugs come in? Now, let's say that Parkinson's disease has no cure for now. And so the drugs we give are mainly to take care of the symptoms. All right. And first, we are saying that our problem, the problems we have, one is dopamine deficiency. Two is cholinergic activation. Now, in addressing this, how do we go about it? So dopamine deficiency. Picture a scenario where you've gone for lectures, you come back, you are hungry. There is no food, so that is the deficiency, there is no food. But you go to the kitchen and realize that you have ingredients to cook. So you can decide to cook the food you want. Now, the same way, if there is dopamine deficiency, we can decide to produce the dopamine ourselves. So we can address this by increasing synthesis. Now, it is also possible that you walked into the kitchen and realized that, okay, you don't have enough ingredients to prepare the food you want, but you have money. So you could then decide to order the food, and then they bring the food to you. Now, that food would represent exactly what you could have cooked if you had the ingredients. So here, we could say that in addressing the dopamine deficiency, we could decide to give a drug that mimics the action of the dopamine as though we have dopamine. So mimic action of dopamine. Now, also picture a third scenario where, although you have food at home, you needed the food for 7 days, but you realize that the food will not be enough for 7 days. And there is no other way to get in extra food. So now you begin to ration the food you have. The same way, because there is dopamine deficiency, we can decide to reduce how quickly the dopamine is being broken down. So we inhibit dopamine degradation. So these three methods are the ways we address the dopamine deficiency. Now we come to the cholinergic activation. Now, we are saying that where there is a dopamine deficiency in the striatum, that would ensure that there is cholinergic activation going towards the cortex. And so we could give a drug that blocks the action of the acetylcholine. So we give anti-cholinergic agents. Okay, so basically, this is how we use drugs to address the symptoms that arise in Parkinson's. There may be other additional drugs we give, but this catches most of what we want to do. Now let's pick them one by one. So in terms of increasing synthesis, what do we do? Let's pick neuronal terminal, right? Let's start from tyrosine. Tyrosine is converted to dopa by tyrosine hydroxylase. So tyrosine hydroxylase. Then dopa is converted to dopamine, right? DA, and this is put in our vesicles. Okay. Now, this dopamine can then be released, act on receptors downstream, which would then help in regulating the motor activity. Okay. Now, We cannot give dopamine itself because it is too polar to cross the blood-brain barrier. So if you give dopamine, it cannot cross this barrier to get into the brain. And so what we do is to give a precursor of the dopamine. Now, if you look at the synthetic pathway, you realize that tyrosine was converted to dopa. Dopa could exist as the level form or the dextro form. The level form is the active form. So the level dopa was then converted to dopamine. So we could decide that we will give levodopa, which can easily be carried from the GIT into the bloodstream by aromatic amino acid carriers, and then they can also be shuttled into the brain. And so once they get into the brain, the levodopa can then be converted to dopamine. And so what we give, instead of giving dopamine, we rather give levodopa, which then gets to be converted to dopamine. So that is how we increase the synthesis. But there is a challenge. When you give levodopa, the enzyme, we call it L-aromatic amino acid decarboxylase, or we call it dopa decarboxylase. This dopa decarboxylase, let's just write DDC. This dopa decarboxylase is not only found in the brain. It can be found in the GIT, it can be found in the liver, it can be found in the kidney. So when you give levodopa orally, by the time it gets to the brain, about 80% of it has been broken down by that enzyme. Okay, so you have less amount of it, and you probably would need higher doses, which will lead to more side effects. Okay, so what we do is that we give an agent attached to the levodopa that would work on those enzymes that are found peripherally. So the enzymes that we find in the liver, in the GIT, and then the kidney, the drug would inhibit those enzymes so that we'll have enough levodopa get into the brain. And so there we can decide that instead of giving levodopa alone, we give levodopa together with carbidopa. Now, the carbidopa is described as a dopa decarboxylase inhibitor, peripheral dopa decarboxylase inhibitor. Another example is benserazide. And so we can give levodopa, carbidopa together, brand name Sinemet, and then levodopa, benserazide together, brand name Prolopa. Okay. Then we come to the next. How do we give drugs that mimic the action of dopamine? And so we are saying that assuming we have a postsynaptic neuron with the dopamine receptors, if dopamine acted on these, we can help regulate the motor activity in Parkinson's. So we would then give drugs that will mimic the action of dopamine, activate these receptors, and help in regulating the motor activity. And so we call these drugs dopamine receptor agonists. There are quite a number of them. We have bromocriptine, which is Palodel, Pegolide, which is Prasend. We have ropinirole, which is Requip. We have pramipexole, which is Mirapex. We have rotigotine, which is Nupro, and then apomorphine, which is Apocrine. These drugs work just as well as the levodopa drug. In fact, we consider these two classes as the first line drugs for Parkinson's. They may come with a number of adverse effects like gastrointestinal adverse effects, Parkinson-like, psychotic-like symptoms, ulcer or gastric ulceration. So there are quite a number of adverse effects they come with, but these are first-line agents. Then we will move on to how we reduce the dopamine degradation. Now, when the dopamine is synthesized, there are two enzymes that can destroy it. We have the monoamine oxidases, mainly the monoamine oxidase B. Then we also have the catechol O methyltransferase. These two enzymes can destroy the structure of the dopamine. Already in Parkinson's, we have dopamine deficiency. So destroying more dopamine means that we are going to worsen the deficiency. So we give agents that inhibit these enzymes, and they are able to elevate the levels of dopamine. Mostly these drugs, we use them together with the first line agents. So here we have monoamine oxidase B inhibitors, such as selegiline, MSAM, and then we have rasagiline, which is Azilect. We also have the COMT inhibitors, entacapone, which is Comtan, and then tolcapone, which is Stamsa. Now let's look at another class of drugs. So here we are looking at how we suppress the cholinergic activity. And so I've told you that because of that decrease in dopamine levels, we have increased cholinergic activity, okay, in the cortex. And this leads to the tremors. And so by giving agents that block the action of the acetylcholine, we are able to bring down the tremors at rest that the patient experiences. So these anticholinergic agents, we have benztropine, which is cogentin. We have trihexyphenidyl, which is attain. We have procyclidine, which is chemadrin, and then phenadrine, which is Norflex. Now, we could also use certain antihistamine drugs that have anti-muscarinic effect. For instance, we can use diphenhydramine, which can be used in mild forms of Parkinson's. We could also use some tricyclic antidepressants that have anti-muscarinic effect, like imipramine, that's tofranil. So imipramine can also be used. So these could be used as adjuncts, but the main anticholinergic agents are what we have on the board. Now, lastly, there is this antiviral drug called amantadine, which is also used in dealing with the symptoms of Parkinson's. Now, when we pick amantadine, we are not too sure of the mechanism of action, but what we know is that it can increase dopamine synthesis and release. We also know that it blocks glutamate receptor activity. And by these actions, they get to manage the symptoms that occur in Parkinson's. The only challenge is that this drug is usually effective for just about a few weeks, but otherwise, it's also a good agent that could be used. Now, this is all time would allow us for now. I hope you have enjoyed this lecture and you found it quite simple to appreciate. Until I come your way again, it's bye for now. This is Professor Kennedy Eden Kupian. And don't forget to subscribe to our YouTube channel.